I'm one of the HEMOC attendings. My name is Jeff McGee. And so Dr. Simke is going to be one of the main people that you see. I'm covering for one of her main clinic attendings, so I'm going to help get everything started for him. You will meet another person or two as we go forward in the attending role as well. Okay.
Can you hear okay on the phone?
Mom, mute your phone. If you hit mute on your phone.
Okay.
Yep.
So I know you guys have been talking a little bit, kind of leading up to this meeting, I'm sure, and so we've heard kind of a lot of the same pieces of information, but I just wanted to kind of start back where we were last week to make sure we're kind of on the same page with what we know so far, and then kind of what our thoughts are about what we need to kind of do next to take care of Vinny. Okay?
Yep.
So the pathology from the tumor showed that it's a type of tumor that we call a malignant rhabdoid tumor. Like you guys know and have read a little bit, I think it's a relatively rare tumor in children. And it's also rare to find it in places that's like where his tumor was in the heart. Usually these are tumors that we see kind of down by the kidney or sometimes by the brain. And so in the heart it's a little bit less common spot. Okay. Unfortunately, this type of tumor is a very aggressive type of tumor. It's just unfortunately one of those things that we just know about this type of tumor to start. Okay. And so I'm sorry that we're kind of starting at that point. But we do know that there are some things that we can do to try and treat the tumor and give him the very best shot at doing well. Okay. So what we've been doing this past week is trying to get more information about where else the disease could be. So we know that there are different types of places that this tumor tends to like to go, including the bone marrow and the bones and some different areas of the lymph nodes and different other tissues within the body. So that's what all the different tests this week were kind of helping us figure out. And so we have some.
I have nothing to add.
Some of those results back, and some of those are still kind of pending. And when we get those, I'll let you know. But the kind of three main things that we were looking at were the PET scan, which is looking at how the tumor cells are a little bit more active than regular cells. And so they tend to light up on the PET scans. It shows that they're using more sugar. So that was kind of the first test that we looked at. Does that make sense so far?
Yeah.
Okay. And so the PET scan kind of looked at kind of all the different tissues of the body, and it showed that those lymph nodes by his belly, again, they're still looking a little bit big.
Okay.
And when we look at the PET scan, they're kind of amounts that lights up, and his are lighting up kind of in like a medium amount. So kind of like the CT scan, it's like a little bit intermediate, and kind of we're trying to figure out the best thought on whether this is tumor or not.
Okay.
I think knowing that he has this tumor in his heart, it's hard not to say that this could be tumor cells.
Right.
And even though they're not lighting up quite as much, I would still think of it that they could be tumor cells. And the way that we kind of think about that and know is in time, if we kind of follow it, if they change, then we might know that they were tumor cells that got better.
Can you see them like in a scan or?
Yeah, so there are kind of a couple different scans that we looked at. First was the CAT scan that showed that they were a little bit big, the lymph nodes by his belly. Then we looked at the MRI that showed that they were still a little bit big. And then the PET scan is showing that they're also about the same size, but they also kind of light up a little bit brighter than the other tissues, which makes us think that they're dividing and growing a little bit faster in the other tissues, which makes us think that they're probably, again, healthy tumor cells. Okay.
To really definitively identify them, we need to go get a biopsy of those lymph nodes. If it was tumor or if it's not, it doesn't really change the management plan. So I think the only thing that would accomplish would be delaying him from starting treatment. And so I think the benefit of finding that out definitively isn't worth the procedure.
So how do you find that out?
Well, so again, it's going to be the same treatment whether it was just local to the heart or not. So we already have a tissue diagnosis, a piece of tissue from what they took out of the heart showing that it's definitely this malignant rhabdoid tumor. And I think we would just, as Dr. Simke was saying, after he gets treatment, we'll look at it again and see if they shrink and if the signal goes away, and that would be more consistent with the tumor responding.
Okay. Sean?
I agree so far.
Okay.
I've been helping cancer kids for 7 years outside of work and stuff, but yeah.
Okay.
So I'm pretty familiar with everything you're discussing.
Okay. Okay.
I'm sorry, I feel like I'm kind of awkwardly saying, so please jump
Oh,
in.
you're fine. You're fine. You're fine.
So that's kind of the PET scan part of it. The important part of the PET scan is it didn't show anything else that looked worrisome. So that's helpful to know to start. Okay. The second test that we had back is the bone scan that he had done, and that fortunately doesn't show any evidence of disease in the bones, which is good.
That's good.
That is good, right? I mean,
Yeah, it's good. It's good news.
okay.
I know. Take good news as it comes, right?
Yeah, absolutely.
The third piece is the bone marrow test, which is one of the tests we're still waiting on. I talked with pathology right before you guys got in, and they're looking still at some of those special stains. I know we talked a little bit with what we were talking about earlier this week was kind of how we look at the tumor cells themselves, and we do some special stains on the tumor cells to look and see if they show these proteins that are very specific for this rhabdoid tumor, and they're still waiting for them to come back.
What's a normal timeline for your bone marrow?
They're expecting that if they don't have to do more stains, they'll have it back probably today or Monday. When they stain them, they have to give it some time for the antibodies to bind to the proteins before they wash them off. And so they're expecting that if the stains are final today and they don't have to do another level of staining, they would be back today. But potentially if they have to stain them again, it would be Monday before they'd have them back.
I wouldn't interpret the time that it's taking as a bad sign.
Oh.
It's very typical that it takes several days. For the solid tumors in particular, leukemias, you can usually get a faster diagnosis, but this takes it stepwise. They have to fix the sample in formaldehyde, then they get their first look, then they do their first set of stains, and that leads you down the step towards the second set of stains. You looked at it, and we didn't see any tumor cells, but the stains are really the definitive thing.
Would that change treatment if?
Again, not really, other than it changes how we would, again, think of prognosis, honestly. So the more limited it is, I think the better it is. But the actual treatment approach is going to be the same, whether it was stage 1 or stage 4 disease. So.
Okay.
So, what is the treatment?
Yeah. Do you have a treatment?
Yes, we do.
Yeah.
So, like we've talked about a little bit, the tumor is typically one that we see by the kidney, and so kind of a little background, initially when many decades ago we started treating this type of tumor, we treat it like a kidney tumor. And what we found over the years is that it doesn't really respond quite as well in the same way as those other types of kidney tumors. There's something about it that just is different, that doesn't respond quite as well as other classes of kidney tumors. And especially with it not being by the kidney, I think our thought was let's take a step back and think about what the tumor is and what other types of tumors we know respond well to treatment.
Okay.
And so what we're proposing is that we would treat it like other types of tumors that we find, the rhabdoid tumors in the brain and the spine. Because in thinking about the tumor, it has a certain protein that it doesn't make, and that is very specific for this type of tumor. And so in that way, we're thinking that when we treat it like the tumors that are in the brain and the spine, it should respond similarly. When they did the initial study that looked at that, they included children that had those types of tumors in other places. When they reported the data, they don't split it out though. So we have the paper in the study that's been done for many years now, but we don't have specific data to say for children with Vinny's type of tumor, this is how they would do.
But the key point is that they did better than the patients who were getting the kidney type protocol. So even though this is a brain tumor regimen, we're going to omit some of the chemotherapy that he would get to his lumbar, to his spinal fluid, because he doesn't have cancer there. But yeah, the key point is that it seems to have a better outcome.
Okay.
So that's kind of the overall big picture of what we're thinking for the treatment plan. And so I'd like to kind of pause because I imagine you guys have some questions about that general part of it.
Right. Timeline, treatment,
As far
starting
as,
Tuesday.
Yes. Yeah, we plan right now to start Tuesday.
Okay.
The type of tumor, unfortunately, is a very aggressive tumor, so we don't want to wait too long.
Right.
We're talking Vincristine.
So it's a combination of several different medicines, including vincristine. If you're familiar with kind of the different,
Red Devil.
Yeah, the different
Devil.
spectrums of things.
Yeah.
This combination of chemotherapy includes most of the different drugs that we use in children with solid tumors. And we'll talk through kind of each of the medicines as we get there.
Do you already have set every treatment? It's all lined out.
Yeah, so there's a treatment protocol that was based off of this type of tumor that is a repeating cycle of things.
Right.
And so there's like a start where there'll be a more intense kind of set chemo, and then there'll be a couple weeks, and then you'll get a little bit less chemo, and then it just kind of repeats. And the combination of medicines changes up every couple weeks, so that's a different variety that this tumor is seeing. That's kind of like
Trying to confuse the body.
Yeah, to make sure that the tumor sees lots of different drugs that work in different ways, and so that the tumor cells don't develop resistance to any one particular drug.
Right.
Okay.
Does that part make sense so far? Okay.
Anyway, yeah.
So the initial phase of the chemotherapy is pretty intense. It's not uncommon that I expect that you feel kind of poorly right after, and so I know it's right before his birthday, but I think it's really important that we start next week rather than
No,
later.
yeah, we agree.
Okay, great. So I can kind of talk you guys through the different medicines and kind of what to expect with that a little bit too. Does that part sound okay so far? Are there any other questions about like the general treatment or why we're thinking this is a better treatment plan?
How long, when you administer it, how long does that take, and what does that consist of? Just him being hooked up to getting it administered in his body? How long does that take?
Yeah, it's a good question. All of the chemotherapy medicines run over a different amount of time. But when he's here for kind of that longer, more intense cycle of chemotherapy, it would be a couple days, and then you guys would go home. And then once that less intense cycle of chemotherapy would be just a shorter day, either in the hospital or in clinic. Then you get the medicine, then you guys would go home.
There may be there probably will be hospitalizations in between if he gets fevers or infections, or if he's just not feeling well enough to eat and drink, which is a common side effect.
What about when his immune system is so low? Will you keep him just to keep him
Safe.
hospitalized and safe from environmental, or?
So on these regimens, typically we let him be home.
Okay.
But if he were to spike a fever, we would bring him in, and then he would be here until his immune system recovered.
Got it.
There's very few tumors where we actually keep the patients in the hospital all the way through. Some of the leukemias we do that with.
Right.
But typically he'll be able to go home after the chemo, and then if he's feeling lousy, we would bring him back in at that point.
Okay.
So.
Okay. You think?
Yeah.
Go ahead.
A thousand different things I want to ask. I don't even know where to start. Second opinions with doctors that have probably dealt with something more similar to the tumor on the heart.
Well,
versus you guys haven't seen it. It's not very common, so.
Right. I mean, we'd be happy to arrange second opinions if you want it. I think that the reason that people haven't seen it a whole lot on the heart is because it doesn't occur much on the heart, period.
Right.
And so, we can, I can contact somebody down in the solid tumor clinic at St. Jude, for example. I'd be happy to try and, arrange a consult down there.
The issue at hand is that you waste a lot of
set
time.
some time back. One of the guys is a really good friend of mine. I'd be happy to just give him a phone call if that would make you feel better.
I just had to ask.
Yeah.
Although I know in my gut, like, the smartest thing is to do just go ahead and start on Tuesday, because I feel like whatever the regimen is that you have already set up is probably the regimen that they're going to possibly do.
I'd be happy to give it. So in Dr. Simcu actually did email somebody at Cincinnati Children's who has a specific interest in this, and he hasn't responded to your email yet, right?
Not yet.
So we're kind of.
And we had talked about just
but,
that, and it being so rare, and it's not like we look at it, or it's not like me and John look at it as we don't trust you guys or anything like that, because we do.
Let's not even worry about that.
Right. I'm just saying, it's the rarity of the case.
Yeah.
And you yourself had said something to me about talking to other colleagues as well.
Yes.
So if you would make that call for us,
I'd be happy to do that.
Amazing.
So I think it's generally a good thing, especially when things are not protocolized, like just cut and dry, to try and seek additional opinions. Because I think, honestly, I feel like I wish a lot of the institutions around here would come ask our opinion on things, because there's things that when we finally do get the patients, I feel like there's things I would have done differently up front. And so,
right.
I mean, I think we're a more tertiary care center, but I'm happy to, we thought we can't make a person respond to their email, but I have another friend who's, a solid tumor person down at St. Jude. I'd be happy to give him a call and see what he thinks.
Sure.
And if he concurs, and, and that might save you a trip down there too.
Right.
If that's okay with you.
Yeah,
Okay.
absolutely. Now my question is, what if, how long, say we get going on the chemo, how long until we know if A, it's working, or B, it's not?
So that's a good question. Why don't I let you kind of pick that up again, Katie, and then I'll chime in. So
there's kind of I think like another part to that question I'd like to address a little bit.
Okay.
So with the solid tumors, one of the really important things that we do to try and help make the tumor cells go away is to get rid of them somehow, like in addition to the chemo. So either to do surgery and totally take it out, which in the heart is very hard, or do radiation and use a different way of killing the tumor cells, which again, the heart is very hard to do. And some of the things we also would like to do is talk about Vinny at our conference this coming week and talk about whether radiation would be an option.
Okay.
Knowing that this is kind of a difficult spot to use radiation in, right?
Mm-hmm.
And so I've reached out to the surgeon that did the surgery to kind of think about whether they would be able to do other types of surgery. That's hard to know, right? Like when they go back in, tumor doesn't really look any different now that there's not a mass there than the heart tissue.
Right.
And so even if they did that, I don't know that they would be able to tell when they did the surgery if they were getting normal healthy tissue out or if they're getting tumor cells out.
Right.
And the risk is that it's in an area that you don't want to just kind of keep doing more surgery if you don't have to, right? So all that to say that there's kind of a phase of treatment we would do like at the front, and then we would do scans down the road every couple of weeks or so, just every couple of weeks.
Okay.
And it may kind of vary based on how he's doing.
Okay.
So if he's doing great, it may be longer, and if he's showing us that he's having symptoms again, then we may do them sooner.
Okay.
Some of it will be a little bit flexible based off of how he is doing too.
Okay.
So building on the radiation point, one of the drugs that he uses going to get is called doxorubicin. That's actually an important component of treating these solid tumors. But one of the side effects is toxicity for the heart muscle. And so I think we'll certainly talk with our radiation oncology colleagues, but I think there's going to be deep concern about trying to, the heart is already radiation sensitive.
Mm-hmm.
We're using a chemotherapy that's going to be sort of toxic to it, and I've got deep concerns about
what it's going to do
about putting radiation there too. But it is a concerning thing that it makes it more concerning in terms of treating it if we can't resect it and we can't irradiate it. And so, but I think that's why we want to make sure that we're going at it with the hardest chemotherapy protocol that we can, because that might be the best shot that we have of killing these cells. So, we had a conversation with the with the CV surgeons, and they were sort of, I don't know how to say it, they were non-committal on anything in terms of what they could do surgically. He didn't really feel like there was much role for more surgery there, and if they feel like they would damage the heart more with an additional procedure, that's also a concern. Especially if it then led to more, usually we do these in the middle, so if there was more prolonged healing that delayed the chemotherapy even longer and it didn't actually convey a benefit, it might be better just to try and keep the chemo going. Okay. I think that's something that's going to be an evolving discussion. This is not the final word on that.
Right.
So.
Okay.
Are there other questions you guys would like to talk about before I start talking about the medicines themselves?
If the tumor would have been on the kidneys, what's the odds that you guys have seen that here? Kidney.
That we see that. I mean, that's
more common.
It's more common, yeah. And so, but in that case, you can get a better resection and so forth.
So, are there any cases of heart here at this
institution? I haven't seen one. No.
Okay.
And I mean, in the literature, like a handful reported in the literature. It's an uncommon profession.
Research that you do.
So I think it's better to think of this in terms of the biology of the tumor itself. Then the location only matters to me in that we can't cut it out.
Got it.
Okay, so if the biology of the cell itself and it's the appropriate chemotherapy has more to do with the type of tumor it is and the mutations that create it. So there's a very specific mutation that's associated with rhabdoid tumors. And it's in a gene called SMARCB1, if you've been reading about that on Google or whatever. And
which is the worst thing to do, don't read Google.
But, you know, the responsiveness to the chemotherapy is not, you know, where it is. The reason we're selecting this chemo protocol isn't because it's in the heart, it's because it's a rhabdoid tumor. And the outcomes on the brain tumor rhabdoid tumors seem to be better than the kidney protocol rhabdoid tumors. And so we're just going that direction because they're the same flavor of tumor in just a different location. And we're trying to get the optimized chemo approach.
Got it.
The heart is a problem. The rarity of the heart isn't as big of a problem as the fact that we can't have it easily resected. If it was just a part of the kidney, the surgeons would go in and they do their thing. He needs his heart, and so you can't take it out as easily as you can take out a tumor mass or remove a kidney and still have another good kidney. And you can't irradiate it without compromising its function, whereas you can irradiate the abdomen and it won't be a big deal.
What about like a heart transplant?
That's a good question, and the honest truth is I don't think he would qualify with a malignancy, especially with any concern for metastatic disease, but even without it, there's multiple barriers. First of all, finding a heart in a child his size is almost impossible on its own right. But even if you were to do that, it's so precious that they won't give it to somebody who has cancer.
Okay.
And so it's, you know, it's easier to get, you know, we do liver transplants in patients with liver tumors, but it's much easier to get a liver than a heart. And because you can even do, you know, living donors, and it's just, you don't have to match it as well. It's easier to do kidney transplants and find a kidney donor than it is to find a heart. It's just I do not think, you know, we raised it initially, but I just don't see any wiggle room on that. It's not going to happen. I mean, because of the malignancy that he's got. So, and I'm sorry to say that. It's a good question. It was, you know, one of the things that was coming to mind, but we also understand that when you have so few hearts, they just won't give it to somebody who has an underlying cancer. So, and it's because of the chances that it wouldn't benefit him because of the tumor coming back.
Now you say that on the PET that's lighting up, it like the actual stomach or the intestine or what?
It's the lymph node.
Lymph nodes down in his belly by like the big blood vessels by his kidneys.
Remember when they came back and said it looked like inflammation when we thought it was the rhabdomyoma with tuberous sclerosis?
Yeah.
That was the area we did have concern for before even going into the PET, that it could be,
And so this bone marrow biopsy will tell you if it's in his lymph nodes, more so in his body, or
No,
just
it's in his bones. That's what
spots.
that does.
Yeah. So the only way to
the
get
bone marrow,
the lymph node would be to actually go in and take the lymph node out, and I
And
don't think that would change our chemo approach for him. And
Would it help though to take the lymph nodes out? No. Okay.
No, I think this is the success and failure here is going to be determined on how the cells respond to the chemotherapy.
Okay.
So.
I'm sorry. No, okay. If there are any other questions that you guys have right this second, then I can talk through some of the medicines. And then we can kind of take those questions as they come. Does that sound okay?
Yeah.
So there's kind of a long list. And when we talk about the chemotherapy medicines, there are some things that we talk about that are just related to the type of medicine itself. And then there's some things that are common things that we would expect to see. Some things that are less common that we may see, and some things that are rare that we may not really expect to see but are important to talk about. And so when we list them all together, especially when there's so many medicines, it sounds like this long list of inevitable things are just going to happen. I don't expect all of them to happen. I'll try and highlight the things that are more likely to happen. Okay. I just want to kind of put that first because otherwise it just seems like a very overwhelming part of an already overwhelming day. Okay. So the first medicine that we use is something called vincristine. It's a medicine that when cells divide, they use tubules to kind of help pull them apart, and so it keeps those tubules from forming. And so the vincristine stops the tumor cells from dividing that way. It also can affect other types of cells. So your nerve cells are one of the cells that also use those tubules, and so one of the things that we think about and look for is whether the nerve cells seem to be affected. And in young kids, the things that we think about are kind of especially like the fingers and toes. So if it seems like his hands and feet are kind of bothering him, or he's not wanting to walk quite as much, or he's got kind of a funny walk, or he's kind of slapping his feet down a little bit, then those would be things that we'd be asking you guys about and wanting to know about. Those types of things typically go away once the medicine is stopped. So again, maybe something we'd be watching for, but also once the medicine is done, if he's doing well and we're able to stop the medicine, then we would expect those symptoms to go away. Okay. Some of the other things are kind of related to other places that the nerves are. So one of the places that we don't typically think about is the nerves in the gut, and so it can cause a lot of trouble with constipation because it slows those nerves down too. And so when he's getting those medicines, we'll be checking and making sure that he's stooling regularly, and then also likely have him on a stool softener so that he's going frequently. Okay. It's one of the medicines that doesn't tend to make his blood counts be low, so those cells tend not to really have the tubules that are affected quite as much. So when we're kind of thinking about the timing of that medicine, it's one that we worry a little bit less about his blood counts being low with. So I don't expect that to be a very common thing. The more common things are the kind of more nerve-related types of things. There are some very rare side effects that can happen with the vincristine where they can make the sodium levels of the blood be low. And when that happens, it can cause kids to feel really poorly and can also potentially cause kids to have seizures. It's very, very rare. Over several decades, we don't tend to see it in more than a handful of children when we treat many, many children here, but it's something that's really important that if you recently got the medicine, you know something seems off, that you just give us a call. That's going to be the most important common theme. If something seems wrong or different, or you just have a question, that you just give us a call so we can sort out what's going on.
Okay. His urine will be bright red, bright orangish. It's more of an orange.
From the doxorubicin potentially, but not from the vincristine.
I'm sorry?
Not from the vincristine, but from the doxorubicin that he'll get.
Oh, I thought it was from vincristine.
No.
Oh, that's
won't cause any problems.
Okay.
Does the other one go with it?
They're usually given at a little bit different times, but like I said, we kind of mix it up throughout the cycles of chemotherapy, so it's possible there might be some times where they're given close together, and so those times we might notice it.
Okay.
Usually they're given a couple weeks apart.
Okay.
The second medicine that we use is something called cisplatin. It's in like a platin group of medicines, and so the main thing that we think about with this type of medicine is that it can make you feel pretty crummy, where you feel really sick and nauseous, and so we want to do some really good medicines to help with that, and it'll be really important as we're starting out that we figure out which medicines are right for Vinny, because everyone's a little bit different with kind of what medicines help with that. Okay, and we have a lot, and they're very good, but we need to kind of figure out which ones are going to help him the most. Yeah.
But like trial and error to figure it out.
Yeah, I mean, we know like in chemotherapy medicines that are really harsh, we kind of have a general idea of which ones we need to use because we know that's going to need a little bit more help to keep the nausea under control. But it is a little bit trial and error knowing that like for him, these are the medicines that tend to work a little bit better. So all that to say, I think we probably would start with some of the like good, strong anti-nausea medicines, but for him, we may have to kind of tweak things a little bit as time goes on. So when he's getting that type of chemotherapy, it's likely that he's just not going to be feeling very well. He may not want to eat quite as much. He may be feeling kind of sick and throwing up a little bit. And so those might be the times that we're kind of watching how much he's eating a little bit better and making sure he doesn't eat heavy fluids and that kind of thing. Okay. The other big thing that it does is that it can cause trouble with his hearing, and so that's why he had the hearing test today to make sure
those high pitch are the ones that usually go or have issues with is the high pitches
to start.
Yeah.
And so periodically as he's getting treated, we'll check and make sure that we're not noticing any changes. Because if we do, we would talk about what we might do with the drugs.
Okay.
It can also cause some trouble with the kidneys where you can have like wasting of the different salts and the different electrolytes in the blood. And so that's part of the reason that we're checking the blood test today to make sure that everything looks normal. And then as he's getting those medicines, that they would stay normal. We would be periodically kind of checking them.
Okay.
When he comes in to get that, he'll be getting a lot of IV fluids before and after after. So there's a period where after the chemo goes that he'll need additional hydration before he'd be able to go home. So
Okay.
an extra 24 hours. And then were you going to get to this, the immune system effect? Yeah.
Yeah.
Okay.
So different from the vincristine, this is one of the medicines that makes the cells in the bone marrow be a little bit, it hits them really hard, basically.
Okay.
So it can cause them to need a little bit of help with transfusions because the cells in the bone marrow make the three big groups of cells, the red cells, the platelets, and then the white cells of the immune system. So if the red cells and the platelets are low, we can give him transfusions and kind of help support him with that. And so we'll kind of keep an eye on what those counts look like and kind of know when they're low that he might need a little bit more help with that. And then when his immune system is low, it'll be really important that we're watching for fevers. So kind of going
Fevers
forward.
is the big thing.
Fevers
I'm
are
hearing.
a big
Okay.
thing,
All right.
yeah. It's going to be very different from fevers in his older brothers and sisters.
Right.
Just sisters, right?
Sisters.
Yeah, and for the last couple of months for Vinny. If he has a fever at this point, we run it right away, and depending on where he's at with his chemotherapy, it may very likely mean a trip to the emergency room and a stay in the hospital for a while.
Right.
Okay.
Fever signifies a different thing in the context of receiving chemotherapy.
Okay.
Than it does in a child who's not receiving chemotherapy. When we give chemotherapy, the immune system goes down, a particular part of the immune system goes down called the neutrophils. So a term you're going to get used to a lot is called the ANC. It's a neutrophil count. Those are the first responders of the immune system.
Okay.
So you get a little bacteria floating around. They recognize it without even needing to always be informed by antibodies and so forth that something's going on, and they kill it. Those are going to be severely depressed when he gets the chemo.
So they won't work.
So they won't be there to work. And so the risks of, and at the same time, so he won't heal minor injuries as well for the same reason. So even the lining of his gut will kind of be a little bit seepy. So we worry about bacteria from the gut getting into the bloodstream, potentially getting onto that central line that we're putting in, that the plastic is protected from the immune system as well, and potentially causing him to have a bloodstream infection. That's one of the more scary consequences of chemotherapy. And so our response to a fever is to assume it's a bloodstream infection.
Got it.
And treat it as such, even though a majority of the fevers will be due to just some inflammation, maybe because you get, I said, the breakdown of the skin and stuff, and or the linings of the gut, and all the way basically from the mouth to the bottom. You can get inflammation that can cause a fever without any infection. You can get a viral infection, catch a cold. There's a lot of different things that can cause a fever. We treat them as if they're a bloodstream infection. And so we'll draw cultures and look and see if we can identify it, but even if we don't, we're going to treat it as if it is such until his neutrophil count recovers. This is a very important component in terms of the outcomes. So, aside from needing to make the cancer go away, we need to protect him from infections. We need to protect him from the consequences of infections. And so we try and get him, how far away do you live again?
45 minutes.
Okay, so we try and get you to the, a hospital that's close by. I think we usually use within 1 hour. You can come to Children's. Progress West is fine. So if you were to call, we'd say, please take him there. They would access his port, draw cultures, and get him antibiotics, and we try and get that done within the first hour of you calling us.
Okay.
So there's some urgency in those cases because the sooner we can get antibiotics on board, the sooner we can prevent an infection. It goes fast when it happens.
So the best thing is to keep the germs, the bacteria, everything away from them.
So that's the difficulty, is that it's not really bacteria that he gets from somebody else. It's not like the dog slurping his face is the problem. It's bacteria that can come from his own intestine because of the breakdown there, or from his own skin. We're all covered and filled with bacteria, and those things that we live with under normal circumstances and control with our immune system are not going to necessarily be as controlled, or there's a risk that they will have infiltrated. And so, we do worry about the cold viruses that he can get causing fevers, and that can have side effects too, but the ones that we are most concerned about actually come from within his own body. And so, there's keeping everybody away and isn't
Well,
going to help anything.
There's other children that are in school. And
Yeah, I
really
mean, I think
worried.
if they're sick, that's one thing where you want to try and maintain your distance because the viruses can also cause lung problems and so forth. But the more pressing risk typically is these bloodstream infections. So.
Okay.
So, I mean, it's really just kind of good common sense steps. So if somebody is coming home from school, they can change their clothes, make sure that they're not bringing the germs into the door with them. That's totally fine, but you don't have to do anything super special other than making sure everyone's washing their hands really well.
Right.
And that if somebody's sick, they kind of stay away.
Okay.
It's really hard not to want to just put them in a bubble, but unfortunately,
Right.
it's not everybody
Like
else.
it's
usually the
it's not
problem.
necessarily going to make a difference.
Yeah.
Yeah. So, real quick.
Yeah, of
So,
course.
because now mom will like gear kicks in. So he runs a fever. I mean, I can just go to Progress. I mean, I'll call you guys on the way, but head to Progress right away. Period.
Sure.
Okay.
And we want you to call us because we want to be able to talk with
Well,
them.
right, that's what I'm saying.
and
But
we
I
go and give you
can be heading in and
instructions.
call you, not
Yeah.
necessarily have to call you, wait for you to
Yeah,
call back or
yeah.
whatever.
Yeah.
And then, okay.
So, when you guys are at home, there'll be a contact number like through the clinic, like we talked about, and I think, so far you haven't really needed to use other than just for appointments.
Right.
But nighttime, if there's something that's going on, it's one of us that's on call. So sometimes it's me, sometimes it's one of my colleagues, and
Okay.
typically what happens is they'll, tell us that you're waiting on the phone or that you're going to have a callback number, and we call you back right away.
Okay.
The reason, like Dr. Mee says, so that we can get everything else started at the other hospital while you're on your way, so that when you walk in the
That
door,
makes
they have
sense.
everything
Okay.
ready to get you, the
Gotcha.
antibiotics that you need in time, get the blood culture sent, all that good stuff. Okay.
Okay.
So what's nice is that Progress is within our system too. And so
Right.
we're used to working with them.
Right.
What
Sometimes.
other hospitals out?
Well, I mean, so we get patients from 4 hours away, so there'll be really small community hospitals that just don't. They're scared stiff when a child comes in with cancer, and so we really want to make sure that we're out in front of it so we can tell them exactly what they need to be doing, and they appreciate it usually too. So,
Right.
but Progress, we work with them quite a bit because they're part of our system, so they can see all of his records because we share the same note system.
Right.
And for a lot of this, it will, very unusual and non-routine situation will start to feel more routine. So you'll know the things to be looking for, and you'll have a good routine of what to do if something doesn't seem quite right. And all of our families will have like a bag in the car and kind of for that exact reason. Because there's something like that. Other questions before we kind of talk through a couple other medicines? Okay. The next medicine is something called doxorubicin. It's another medicine that kind of helps attack the tumor in a different way, and that's the one that you're thinking of that can cause the tears in the urine to look
They
like
must have done
orange.
something close with, because it was like red.
Yeah.
A lot of them, they sometimes get used at the same time.
Okay.
Yeah,
Okay, then that's what it
yeah,
was.
Yeah. And like Dr. Mee mentioned, it's in a class of medicines that the thing that we worry the most about is the potential for it to affect his heart. We know over many years of using this medicine that there's kind of an amount in your lifetime that if you're below that amount, the risk is lower. And so the studies are all designed and the protocols that we base that off of, basically the recipe for chemotherapy, when we talk about that, is based off of the idea that we want to stay below that amount. Unfortunately for this type of tumor, what we know is that this is a medicine that works very well for solid tumors, especially when we can't take them all out. And so his amount is going to be much higher than other types of tumors that we use this medicine in.
Okay.
And that's part of why we wanted to have the cardiologist look at the echo after they did the surgery, and we knew what was going on. We had them make sure that the amount that his heart is able to contract looked good. And why when he's getting his treatment, he'll get echoes kind of throughout to just make sure that that's not changing. Because that will need to be a discussion then about what we're going to do if that seems like that's a problem.
No.
Okay.
It's also another medicine that might make him feel kind of crummy as far as eating and feeling nauseous. It's also a medicine that targets kind of fast dividing cells like the tumor cells, but it's one of the medicines that will